wearing all this type of all the dress, and then you are not used to it. And if the surgery goes for 2-3 hours, you are really very, very tired, and the surgeons are in a very, very bad shape, and that causes something called traumatic stress disorder. COVID-19 traumatic stress disorder is one of my publication in Indian Journal of Surgery, and this causes a lot of fatigue, and you don't feel like doing a surgery next time. So that's how the entire thing goes. So what should be done? I mean, that is what the problem with surgeons. And my topic is that only, surgery at the time of COVID-19. Now, this is the procedure which are precautions for the operating team to be taken. The members of COVID-19 pandemic, this is a protocol given by the American College of Surgeons. First of all, development of a decision tree algorithm is there based on whether the operation is important or not. As I told you, only the emergency surgery has to be taken. Surgery which can be postponed, or elective surgeries which are not life-threatening can be postponed at a later date. There has to be, you should understand whether how is the anticipated viral burden, and what is the how much aerosol will be generated, and what are the patient's symptoms. All these things has to be taken into consideration. Why? Which patient to prioritize. The evaluation has to be made in toto, where you have to think which patient is important. You have to think about your conserving PP, and your team member has to be protected. Now that's the important chart. How do you select the patients? First is you assess the patient selection, as patient criteria assessment has to be done. Then you do a testing of the COVID and see what is it. Swab, nasopharyngeal swab is taken and do the testing, and then if it comes as negative, you go for pre-op appointments, and then finally on day 0 you enter the pre-op stage. So that's how the testing of COVID-19 is done. Now the important thing, as I was telling you, only the life-saving surgeries, this is a graph which is given, they have to be taken. And life-saving surgeries means there is highest number of deaths from pandemic is occurring. Life-saving surgeries can cause high number of non-pandemic deaths from, the ICU beds may not be available. So you have to segregate all those patients. The patients which can be suppressed are this, or can be done at a later date. So you have to do a graph accordingly and think which patient has to be taken first and which patient can be postponed. Now the SAGES and EA's recommendation for laparoscopic surgery or minimally invasive surgery is very different. The laparoscopy says, though there is hardly any risk of aerosol generation in the laparoscopy, and there's hardly any risk of the surgeons getting a virus from the laparoscopic procedure, but then you have to be very careful. There are proven benefits of reduced length on stay is good, that laparoscopic stays only 1 day, the patient goes off. So that's the benefit of doing. But then you must also think that when doing a laparoscopy, there is a chances of aerosol generation. So that's very important. So there has to be minimum number of staff, and all staff should wear PPE. You have to postpone all elective cases, as I told you. And there has to be minimized face-to-face consultation. Don't start a teleconsultation. And there has, in laparoscopy, you have to have a filter device so that the gas goes out. Your carbon dioxide is going out of the OD without any type of contamination. And the minimum use of emergency devices has to be there. That emergency devices has to be minimum, because there should not be any leak there should not be any too much of cauterization. Now, as I told you, we have consent. We have taken a consent for COVID-19. We have made a different consent form, and all patients are tested prior to the surgery if possible. And there has to be a dedicated OR which is only for COVID-19. You cannot take any other patient in that. So that's how the entire thing has to be done for laparoscopy, if you are doing laparoscopy during COVID-19. Now, an important thing comes next is anesthesia. General anesthesia is dangerous because general anesthesia causes a lot of aerosolation. If you do intubation, any intubation causes a lot of aerosolation. So you have to try to avoid general anesthesia. And if you avoid general anesthesia, what next you have? You have regional anesthesia. So this is again one of my publication in Indian Journal of Surgery. that you must try to use more of regional anesthesia over general anesthesia, because general anesthesia, the important thing of advantages of regional anesthesia is it avoids the needs of airway instrumentation. It avoids the risk of airway management in patients with lung infiltrations. It eliminates the risk of post-op ventilatory dependency, avoid adverse effects of general anesthesia. So in general, regional anesthesia should be preferred over general anesthesia in a case when you are doing surgery in COVID-19. So please remember that, and your anesthetist should be aware of this. Now you should understand what is the impact of surgery during COVID-19. This is a study done in Italy, and they found is very important to have certain things which is very important for protection of the patient. Number one is you have to limit the visitors' time. You cannot keep on the visiting hour has to be curtailed or to be stopped. Don't allow any visitors. Now you have to have a COVID-19 dedicated OR. You have an operating room which is dedicated only to COVID-19. You have to shift the surgeons to some other area, and you have to store the blood components because you may not get blood. And as I told you, you have to cancel a scheduled surgery. So that's a very important thing. Your scheduled surgery has to be cancelled. Only emergency cases to be entertained, and that too life-saving emergencies. You have to take care of post-op surgical care. You have to understand that patient may require a ventilator, and this is how the entire pathway goes. You have to be very careful. As I told you, in a surgery also, you have to see there is a minimal isolation. You have to use a cautery very less, not much of cautery. And you have to see that the isolation is less, and you have to go for regional anesthesia. So all these things are very important in a case when you are doing surgery during COVID-19. Now there is a very important thing, that is how do you evacuate the smoke. I do not know, there are no evacuators which is suction service available, which take the smoke, pneumoperitoneum when you do. After the end of the surgery, the smoke is taken away and is let out of the OT so that none of the OT staff is contaminated. Now, the checklist for COVID-19 laparoscopy is drop less. That's the checklist. And if someone is in pre-op, you have to drop. Drop is don personal protective equipment, restrict personal, OR is with negative pressurization. Your OT should have a negative pressure, and you have to prepare a smoke evacuator with filter. So this is drop, and post-op is less. You have to be lasting dialysis, end insufflation, smoke evacuation by epigastric port, and slow removal of trocar. Your trocar has to be removed very slowly so that it does not cause any type of isolation. Now this is how the guideline goes up. This guideline again is a British's guideline, and they say that emergency, in a case of emergency cases, what investigation to be done? You have to go for CT thorax, because sometimes the RT-PCR study takes time. So you have to go for immediate CT thorax, which has about 95-97% positivity. Detection. So it is a fairly good amount investigation, and you get the report in 1 hour, 2 hours time. So if you are diagnosed, if you are thinking in an emergency surgery, you cannot wait for RT-PCR or a conventional COVID test. Get immediately a CT thorax and get it reported. That will save you a lot of hassles. And then, if you require, you can do a CT abdomen. But CT thorax is the investigation of choice in a case of emergency surgery, where you cannot get immediate RT-PCR or immediate COVID testing. In the theater and all positive cases, you have to give minimum staffing. All staff should have full PPE, and there has to be small extraction and extubation, intubation in the theater. If it is a planned surgery, again, if it's a planned one, you have to think the risk, how much risk you are taking, and you have to take a proper consent. As I told you, the first thing was my consent form. I showed you the consent form. And in a case of laparoscopy, as I told you, again, repeat, this is the guidance, this is the guidelines which I'm showing you. There will be a little bit of same thing I'm telling, but this is the guidance. The risk of aerosol type infection should be decreased. Consider only very selected cases. Filters has to be used. Now, in a case of appendicitis, try to give conservative management and postpone the surgery. Even in case of cholecystitis, try to give conservative management. If internals is internal is gone for a gangrenous cholecystitis, try to do only conservative management and plan elective surgery after a later date. So that's how you can save yourself and your team from getting COVID-19. Now, the SAGE's recommendation regarding surgical response to COVID-19 is very same. This is again a standard protocol all over the world, and that is cancel all elective cases or endoscopy. That means you should not do any type of elective cases in the OT during this time. As I told you, you use minimum laparoscopy, use filters. You have to use PPE, and you have to prevent any type of droplet precautions. Droplet infection should not be there. And minimize people in the OT. There should be only one runner, and that fellow should know what he's supposed to do. Don't use too many people in the OT. Don't keep too many crowd in the OT. Just 1 to 2 people who are dedicated and who are wanted. As I told you, cancel non-urgent clinic. Even the clinic has to be cancelled. Protect yourself, because that's the important thing. At the end of the day, you should be protected. Only then your family will be protected, and you can do the next operation. Suppose you are not protected, you cannot think of the next surgery. It's very difficult. And register your center for COVID surge training, and then prepare to be called for a new role and follow CDC guidelines. That's their country's guidelines. Now, the important thing is, in a case of surgery, post-op. Now, in a case of COVID-19, the post-op problem is this patient may require about 25% cases. There is a high chance of mortality. So even if you do an hydrocele, if the patient suddenly turns out to be a COVID positive, the patient might die 25%. So that's a very high death rate. And 40% of the cases, patient may require an ICU. This study has done in China. And this is the reason why I told you the first you have to take a different type of consent form. And we have to make the people understand, the patient also understand, that there is a 25% chance of mortality and 40% chance of needing an ICU. Those things has to be told to the patient, and that's very important. They have to understand the difficulty position. So, ladies and gentlemen, until the surgery is very, very important, until it is life-threatening, please do not do any type of non-emergency cases. As I told you, the mortality and pulmonary complication in patients undergoing surgery, that's again a study which came out in Lancet. And that, again, the same thing, it's very important that you should be very, very careful. Everybody is telling that post-op, you may have done a fantastic surgery. You may have given a very good job. You may have done a bloodless surgery, but you never know that the patient may die, not irrespective of your surgery, because of the COVID. And that's the reason why they say, until it is very important, until it is life-threatening, do not do any type of surgery now. Now, there are certain phases we have to understand, that's known as phase 1, phase 2. The checklist has to be there. The patient enters the operating room, the checklist by OT staff, regard to lab trolley, all lab instruments, sutures, staples, OT cleaning, everything is done, checked first. That's known as phase 2. When you go for phase 1, then after this check, then goes to phase 2. What is the phase 2? The anesthetists enter the OT. Mind it, now nobody has, the first, the sisters gone, OT staff has gone, checked everything. The second phase starts then. It's like a rocket launch. The second phase is the anesthetist team enters the OT. He sees what is the choice of anesthesia, regional or GA. Regional will be preferred. Then he sees how the safety precautions of doing GA, critical intubation. He stops the laminar AC. He starts the negative pressure OT. That's the team, the anesthetist team checks. Then after, wait for 15 minutes. Very important, ladies and gentlemen, very important. Wait, and then you go for phase 3. Phase 3, the surgical team enters the OT. The protocols to minimize duration and extent of surgery is seen. Safe pneumoperitoneum is preferred. Then he checks the smoke evacuation and filtration policy. Then he sees the minimum use of the energy devices. You have to minimally use harmonic scalpel, all electric cautery. So that's phase 3. Then he goes for the surgery. After the surgery is over, the next thing is phase 4, where there's the exit strategy. How the team comes out. First, the operating team comes out. Then the patient extubation team comes out. Third is the anesthesia team comes out. And last is OT nurse. So that's phase 4. And then you go for the phase 5, where the cleaning and disinfection of the OT is done by the OT technicians. And finally, wait for 1 hour, just after the cleaning and disinfection, wait for the 1 hour, which is phase 6. Only then the OT is ready for the second case. So every phase is important. It's like a rocket launch, as I told you. Every phase has to be maintained and you cannot slip short or you cannot cut short any of the timing in this. Now, the last thing is, when you're starting these elective surgeries, many of the patient party comes and ask you, when I'm going to do the surgery, when I'm going to get my gallbladder surgery done, when I'm going to get my appendix surgery, because you have told them come later on. How long? When do you start the elective surgeries after COVID-19 pandemic? You are doing emergency cases, but what about elective cases? How long can you keep on postponing? The guideline is very simple. The roadmap for starting elective surgery is, if the patient, there's no new cases for the last 14 days in that locality, then you can do a elective cases. So you have to wait, and you have to ensure from your corporations, from your municipalities, from your village, that there is no new cases in the last 14 days. Only then you can do a new elective cases. So till that is the guideline, that's the roadmap for starting a case for elective surgeries. Now, if a patient is having COVID-19, what happens then? And how do you know he's having COVID-19? See, this is how the entire symptoms are. On admission, you think of doing a gallbladder, you admit the patient, you are doing investigations till 2.5 days, nothing happens. He's admitted. You do the surgery on 5th day, suppose, you've done the surgery, nothing happens. The first symptoms comes in around 10th day. That's when the first symptoms come, and that's a dyspnea. So you will be missing your entire thing. The patient is admitted on day 1, and you have done the investigations. On 5th day, you have done the surgery, and on a 10 days, so many days, the patient is infecting everybody. If he's COVID positive, and by the 10th day, the patient becomes dyspnea. By 11th, the patient goes for acute respiratory distress syndrome, and by 16th day, if he is not able to revert, he dies. So that's how the surgical patient, COVID positive patient, the entire path is like this. I hope I'm clear what I'm saying. And as I told you, this is one of my publications where I have mainly dealt with, this is in Journal of Minimal Access Surgery, where I have mainly dealt with how is the personal protective equipment used in laparoscopy during COVID-19 is so damn challenging. It is very difficult for all of us to do surgery wearing a PPE. And I'm not sure how many surgeons in Sudan are able to do it. We find it extremely difficult, and we are not used to it. Now, COVID-19, we are slowly getting used to the use of PPE, and there is a high chance of doing a surgical error because of the dehydration. So that I want to tell everybody, each and every surgeon who's listening today, that you may be doing a lot of surgical error in wearing a PPE, which you will not otherwise, but that does not mean you should omit PPE during this testing condition. Now, the management of COVID-19 cases in OR is, everything has been very set. I'm sure many of you can read this. There's a very specific role for each of us. What is the nurse in charge is supposed to do, what is the OT runner is supposed to do, what is OT nurse is supposed to do, what is anesthesiologist is supposed to do, and what technician is supposed to do. Everybody's role is very important, and I'm sure all of you should see this. This is written very well. There's a preparation phase, there's an intraoperative phase, there's a post-op phase, and there's a follow-up phase. And there's all the disinfection, everything. This one chart will give you all the information which you require for doing surgery in COVID-19. All of you can read it because it's very well written. I don't want to read the entire thing, but it's very clear. And even the specimens handling. Suppose you remove a gallbladder, how do you send it for lab? Everything has to be done. Everything is in a set protocol, and all of you should follow it, and to avoid getting contaminated. The recommendation, again, I told you, recommendation for surgical procedure for potential COVID-19 patients. It is a positive. It's now I'm not talking about any doubt. We are doing in a patient whom we know there's a patient of, there's maybe a potential COVID-19 patient. So in there are recommendations is, to decrease the viral exposures. And then again, I told you the preparations in the operating room. How do you do? You have to leave your pagers and mobiles outside the OT. Please do not bring any of the mobiles inside the OT. And PPE again has to be worn, and you have to wear N95. There cannot be any other mask than N95. You have to wear a N95. You have to have, as I told you before, you have to have a proper donning and doffing of surgical gown. And there are a few things like, you should understand the review of whether you are doing a proper doffing and donning, and your eye protection should be there. Your everything is very set for those things. When you are thinking this patient is having a COVID positive, and you know this patient you're going to operate. Now there are a few things the surgeon should also know apart from the surgery part. That is that there is something called a blood clotting problems in critically ill COVID-19 patients. So in patients of COVID-19 whom you have not diagnosed and you're doing an emergency surgery, even if you're doing emergency surgery, you should understand that there may be a problem of blood clotting. So you should be prepared of it. You may have to give a low molecular weight heparin before doing for surgery. So your low molecular weight heparin should be a part of your protocol because you may not know this patient may suddenly you may have done a good surgery, but then patient may not make it because of some problem. You know, there is a lot of bleeding problems which occurs in a case of COVID-19 patients. So at the end of my talk, I'll say that believe in yourself, and you have to be very important. You have to save yourself because only then, as I told you, you can think of doing your next day surgery. Otherwise, it's very difficult. Now, not many of us are aware of what should be done. Not many of us are used to this type of wearing PPE and doing surgery. All of us are having, in different part of the country, this is the first time experience. So I am sure even in Sudan, all of you should be very careful while treating a patient of COVID-19 or doing a surgery on a patient of COVID-19. So that's my message to all. And I want to thank everyone who is ignoring social distancing and everyone who believes that's a political hoax because it is not. So you have to, this is a coronavirus talking, you have to be very important, and you have to be very important to treating this corona, and you have to be very careful of doing surgery on those patients. Thank you. Mohammed, am I audible?
Yes, absolutely. Clear.
Okay. How was it? Is the talk okay, sir? Was the talk okay?
Really, the talk is a very interesting and it's very informative.
Thank you, sir. Thank you, sir. I hope you all enjoyed it.
Yeah, it is enjoyable talk, and I would like to have some comment.
Yes, sir. Please, sir. Please, sir.
First of all, we know that COVID, it put our practice really in a real challenge, and all of us, medical and non-medical personnel, we are lagging behind about knowing all the information. So we are gaining every single day because this is a very dynamic disease. And fortunately, when the intercollegiate documents and the SAGE, Society of American Gastroenterologists, release their documents about COVID, the Sudan Society of Gastroenterologists, they release a very nice document. I hope that all registrars, they encounter it during their practice. I'm very interested about your talk in the donning and doffing for surgeons, that they have facing a lot of challenge regarding the dehydration, fatigue, and so on. Now, my question, as we are consenting patients with a COVID, with a certain areas that need of ICU, the problem of coagulation, and even the respiratory problem and gaining COVID post-surgery because of the anesthetic effect and so on. Now, for the staff, if there is any way to have such a consent, especially for those paramedic staff, do you have faced any such practice?
Teach them how to, but we don't have any. Problem is, paramedical staff, the people, the doctors get proper PPE, the sisters get proper PPE, but many times the paramedical staff do not get it, or they do not understand the importance of it. So they are in high chance. So we try to keep them out of the OT. We don't want to get them involved majority of the surgeries, but doctors and the assisting team, many of the paramedical staffs do not get the PPE due to the scarcity. Sir. Hello.
Hello.
Yes, sir. Please tell.
We really enjoy this presentation on
Thank you, sir.
behalf of
Thank you very much,
our
sir.
Sudanese Surgical Club. Great thanks, sir, and we hope to see you soon.
Thank you, sir. Thank you very much, sir. Thank you.